Next, I invite Dr. Saneesh P J onto the stage. The moderators for this session will be Dr. Arun, Associate Professor of Dr. Mupin's Medical College, Wayanad, and Dr. Ruby, Assistant Professor of Dr. Mupin's Medical College.
Good morning, everyone. Our next session for the day is Physiologically Difficult Airway. For that, we have got an eminent speaker, Dr. Saneesh P J, who is a Senior Consultant, Anesthesiology and Critical Care Department, Ananthapuri Hospital and Research Institute, Trivandrum. Sir has written various books like Review in Clinical Anesthesiology for Postgraduates and Textbook of Anesthesia for Technicians. Sir has got various publications in index journals, conducted lectures in CMEs, conferences, and various workshops. For aiding in the academics of PGs, he has got a YouTube channel and an Android app called Anesthesia Tools and website called www.onlineanesthesiatools.com. It's a great honor to have you on stage, sir. Over to you.
A very good morning to all. Thank you very much for the kind invitation and your introduction. Very happy and thankful to the organizers of ISA Midcon for having me here. Actually, this is my second session. Yesterday we had a case discussion. So thank you very much, and let's begin with the topic. This is about physiologically difficult airway. So in another 15 to 20 minutes, we'll try to go through quickly how to approach a difficulty beyond anatomy. We are all familiar with what we used to discuss and prepare as difficult airways. It's like taming an elephant. You know the terrain is difficult. The battle you are about to get into is also challenging. And most of us nowadays, at least for anticipated cases, we go and attempt this with adequate preparation. There are also other situations where our anatomical indicators of anticipating difficult airway may appear to be very easy. It's like going to tame a god. But you look around, you realize that the terrain is difficult, very turbulent, and unless you are prepared, you might return with a sheepish smile. In acute medicine, in critical care, our ultimate aim is to simulate or bring the patient back to a normal physiology. And in acute medicine, many situations, we are likely to crash against a set of conditions which I will be abbreviating as crash. And this is exactly what we will be discussing. Just to give you an idea, this is a patient post-trauma, apparently a lean patient, probably he is talking, but his upper airway is bleeding. Your thyromendal distance, your myelopathy, everything is normal. Is it the same like you handle a difficult airway management? No, we are into probably emergency room or ICU or sometimes in the OT, but the situation is difficult. There is potential anatomical and physiological alteration because the patient may be hypoxemic already, patient may have blood, there may be cardiovascular impairment because after a stage hypovolemia per se will lead to other cardiovascular comorbidities or like compensation mechanisms may be exhausted, and the patient may also be in an acidotic milieu. So it's not about handling airway with a normal laryngoscope and probably an experienced anesthesia provider. You might have to do a lot of other things also to manage this case. Probably you have to do the bleeding control. Something like tranexamic acid or antifibrinolytics may be initiated. If possible, local measures to control the bleeding, especially from the airway, may be instituted. If patient is already hypothermic, hypovolemic, coagulopathy is a dreaded combination. Metabolic acidosis correction, and we try to maintain normothermia before we actually embark upon the airway management per se. So basically the idea is to bring the physiology back or have the preparedness to anticipate the issues related to the physiological derangement and then probably proceed to your airway management. Of course, a similar case, you can't have a conventional airway management. Probably we may have to plan for an awake airway approach and probably an preemptive cricothyrotomy or tracheotomy may be planned. So this is our theme for this lecture, physiologically difficult airway. The word actually came into literature as late as probably in 2015. So this presents itself independently of our anatomical airway indicators or predictors, and as acute medicine personnel, we are mostly into emergency airway management. And these conditions pose unique challenges because of the infrastructures, because we may be handling it in emergency room, maybe in cath lab, maybe in endoscopy room. So equipment limitation, the human factors, your senior airway person availability factors, altogether we are actually looking into an increased morbidity and mortality. So it's not an easy airway when there is these conditions in the backdrop: hypoxemia, patient already hypoxemic or in shock, patient in severe metabolic acidosis, and patients in right ventricular failure. The bottom line is the physiological reserve is minimal and there is high aspiration risk also adding to your woes. So how to approach a physiologically difficult airway? This is the Makocha score, which has been described for emergency airway evaluation. So this contains factors related to the patient, factors related to pathology, factors related to operator. So I think everybody will be familiar with this Makocha score, and the last portion is non-anesthetists, which is not applicable as we anesthetists, when we anesthetists per se are involved, but still when the points increase anyway from 0 to 1 to approach 12, the difficulty increases. So it's not about anatomical indicators, it's about physiological markers as well. Another commonly used criteria is Heaven criteria, which will use hypoxemia, extremes of size like pediatric age group or clinical obesity, anatomical disruption or obstruction as in case of trauma, mass swelling, foreign body, vomit, blood, fluid, that is significant fluid is present in the pharynx or hypopharynx. Patient is exsanguinated like in severe bleeding, hemoglobin drop, neck mobility issues and neurological injury where the cervical range of motion is compromised. So Heaven criteria is another one we will be using when we plan for physiologically difficult airway. So one thing we do routinely right from our earliest days in anesthesia training is pre-oxygenation. Why do we need pre-oxygenation? Because our airway intervention per se can drain oxygen reserve, because we need to build up oxygen reserve. That is one thing. Second thing, emergency situations, airway management may not be straightforward. It can consume more time than you anticipate. So we need to build up enough oxygen reserve. So there are some maneuvers which are described like keep the patient head up when possible, rammed position, reverse Trendelenburg position. These will help improve the oxygenation or efficacy of pre-oxygenation. I will be discussing something more about methods of pre-oxygenation. These days we also discuss about apneic oxygenation. So from pre-oxygenation now we are into para-oxygenation, where our oxygen supplementation efforts will persist even during our laryngoscopy or airway interventions. The idea is to minimize apnea time. Rapid sequence induction, whenever in emergency situation, mostly it's indicated. It should be considered in patients with high risk of pulmonary aspiration, upper airway bleeding, GI bleeding. Anyway, patient has to be considered as full stomach. And delayed sequence intubation, I think for the residents this is very important, because our target is improving oxygen reserve. So if the patient is anxious or agitated, unable to cooperate with our pre-oxygenation maneuvers, we can always try to do another pharmacological maneuver to buy time to improve your pre-oxygenation maneuvers. Again, while choosing your drugs, you can actually disrupt the physiology further. Like if you choose propofol, you are likely to have further hypotension, especially when you are handling a hypovolemic patient. So drugs like etomidate or ketamine will come as better options, but again the final decision is determined by the scenario. Type of laryngoscopy, now we don't depend on our conventional laryngoscope anymore, at least for emergency situations or non-operative room interventions. We can always plan additional airway gadgets like video laryngoscope, and some conditions, some situations definitely demand keeping the patient on his spontaneous breathing and plan for awake intubation aided by fiber optic. So I said during our intervention oxygen levels can drop and it can put your patient's life into jeopardy. Same is the case with the hemodynamics. During your intervention, during your drug intervention or your procedure, or during the apnea time where you are intervening the airway to save the patient, that itself can have hemodynamic implications also. Probably the patient is already hypovolemic, already depleted of hemoglobin because of the exsanguination. So we need to do something to optimize that physiology also. So how do we do that? Fluid resuscitation, easier said than done, because some patients overloading of fluid can be costly. Suppose you are handling a physiologically difficult airway in cath lab. So fluid resuscitation may not be the first choice. Maybe early institution of vasopressors you can consider, because you need to tide over that hemodynamic fluctuation. Right heart failure patients, probably you can even think about pulmonary vasodilators for RV dysfunction patients, and even some cases getting ready with ECMO facility might be a prudent option. A little bit on pre-oxygenation dispositives. As I mentioned in the earlier picture, you may be trying to tame a goat, but initial part will be to maintain the stability of your terrain, the bridge. The bridge should be strengthened. You should have control over the scenario, then only attempt this, because that will improve your first pass success or the complication. Even if you attempt your first pass or first attempt is successful, your idea is to avoid a cardiovascular collapse or a severe desaturation. So traditional pre-oxygenation I have already mentioned. We can use a tight fitting face mask either with the anesthesia circuit or a bag valve mask. Non-rebreathing mask can be used 3 to 5 minutes when time and situations permit. You can also augment your maneuver, this conventional maneuver, with a head up position or ramp position depending on the patient, and even reverse Trendelenburg position. Of course, everything has some caveats, like if patient is already hypovolemic, allowing the blood volume to be parked in the lower limbs may not be a good option when you are speaking about reverse Trendelenburg position. So there is no one size fit for all solution, but you need to keep these options in mind. And when you are using some sedatives, it should be preferably non-respiratory depressant, probably something like ketamine or dexmedetomidine. This is the widely practiced one, wide-bore nasal prongs. So for short period you can have high flows, because our idea is to improve the oxygen reserve. Newer methods, especially after COVID, we have been using HFNO or Thrive either inside the OT or outside the OT, because it delivers heated humidified oxygen. You can supplement almost 100% oxygen with HFNO, and that is humidified, that is more physiological. And this allows flushing of the dead space, reducing the carbon dioxide in the dead space, and it decreases the respiratory rate and improves the thoracoabdominal synchrony, reducing the work of breathing. That optimizes the condition before your intervention. So this has been an effective alternative compared to our NIV option, and it can be used during your intervention. That is the advantage, and it can be used for awake intubation, and it's useful for patients who cannot tolerate tight fitting or non-rebreathing mask or NIV, because the patient is agitated either due to head injury or due to patient's claustrophobia or other issues. But our idea is to bring up the oxygen reserve. But the disadvantage, literature mentions a variable PEEP-like effect, but the PEEP effect of HFNO is usually very insignificant. And some cases, especially patients with the shunt, you are raising the FiO2 may not work per se. So there recruiting the lung units is going to help you. So in such cases, NAV is the option. Again, you can deliver high oxygen concentration and it offloads the respiratory work, avoids the fatigue and prepares the patient for your airway intervention. NAV is considered to be superior for patients with significant shunt physiology or reduced FRC. So it is considered as a better method of pre-oxygenation in patients with moderate to severe hypoxemia. But there are some disadvantages. Suppose you are handling a case in cath lab, minimal pulmonary edema you can manage with NAV. But for your intervention, there is a switchover period where you take out the positive pressure for a transit time. There may be a possible de-recruitment of CPAP. And of course, NAV in a compromised, hemodynamically compromised patient can have hemodynamic changes related to the positive pressure. And unanticipated NAV institution, patient is agitated, anxiolysis and sedation also may be needed. Inside the OT, you can also consider use of supraglottic devices for maintaining the pre-oxygenation airway. Of course, there are some disadvantages. As I mentioned, the more you keep on positive pressure, the switch over a sudden release of positive pressure can cause de-recruitment. Nowadays, we are also discussing about apneic oxygenation. So even without a positive pressure ventilation, we can continue oxygen supplementation, and due to the apneic oxygenation, some amount of oxygen reserve will definitely be augmented. So in the picture you can see that there is no positive pressure ventilation. This is just apneic patient, but still you can see almost 250 milliliters of oxygen gets into the pulmonary circulation every minute, and only 10 ml of carbon dioxide per minute is diffusing back into the alveoli. So 250 lost, only 10 is coming into the back into the alveoli. So there is a drop in volume. It definitely will create some negative alveolar pressure that will draw in further 100% oxygen into the alveolar units and will maintain oxygenation. So that is the principle behind that. So for physiological airway, what we can summarize is we can have a personalized pre-oxygenation plan. If there is desaturation risks, no, then you can even plan for awake or spontaneous breathing patient. You can plan for awake intubation like in case of facial trauma. But desaturation risk is there. Next you check for FRC whether it is compromised. Then you can check for other factors like refractory shunt, whether patient is vulnerable to further apnea. So you can have an algorithm either as a hospital practice or some literature mentioned algorithms are available. So I'll quickly go through a few scenarios like in hypoxemia, patient already severely hypoxemic. So there is a potential arterial oxygenation problem. So we need to handle oxygenation, hemodynamic stability, we need to avoid hypoxic brain injury and to avoid CPR. It can also be due to shunt. I mentioned increasing FiO2 is not going to work. Measures to reduce the V/Q mismatch is what is going to help you in such scenarios. Cardiovascular impairment, fluid responsiveness, you need to find out by the point of care devices like ultrasound, and that will give you an option to judiciously administer fluid resuscitation, and early administration of vasopressors is going to help you. And you can always have short-acting boluses of ephedrine, phenylephrine or epinephrine to help you with that tide over crisis. Induction agents, lots of agents. You can think about the cardiovascular implications and choose your agents. RV dysfunction I have already mentioned. Point of care echocardiography has been very much practiced in many institutions. You can always use this point of care device, echocardiography, to assess the right ventricular function and to guide the management of fluid therapy, mechanical ventilation, and even some cases will demand pre-intubation ECMO cannulation. Patients in metabolic acidosis, you need to know the reason, how much patient is compensated, and during your intervention try to maintain the compensation as much as possible, because any extra apnea time will increase the PCO2 level because of the respiratory compensation loss, and it can have catastrophic scenarios. Neurocritical patients, apart from these considerations, we also have to maintain adequate cerebral perfusion because autoregulation may be disrupted, so you need to maintain that tight hemodynamic control and avoid the risk of secondary neurological injury. So avoid hypoxia, maintain normocapnia, stable hemodynamics, these are the extra challenges. High aspiration risk, whenever your saturation is at risk, gentle mask ventilation is advocated because a patient with aspiration is better than a dead patient without aspiration. So these are the conditions where physiologically we get physiologically difficult airway, like in pregnant patients and pediatric patients. The reason we already know. So this is a summary. These are the crash scenarios. C means consumption increase, like in sepsis, hemodynamic, hyperdynamic circulation, hypermetabolism, etc. R for right ventricular failure, A for acidosis, metabolic acidosis, S for saturation issue, severe hypoxemia, H for hypotension, hypovolemia. So this is the abbreviation crash. So beware of crash. Your time for intubation may be limited. Thank you very much for the patient listening. I have been trying to bring out some indicators which will help you to prepare the possible physiologically difficult airway, manage better. Thank you very much.
Thank you very much, sir, for that excellent presentation. And being postgraduates as well as junior anesthesiologists, we are actually more worried about the anatomically difficult airway. Thank you very much, sir, for highlighting the importance of anticipating a physiologically difficult airway, like cardiovascular instability or respiratory instability, and the need for stabilization of the patient with drugs, devices, as well as strategies. So now we can have a few questions from the audiences we have. If there are no questions, we will wind up the session.
Thank you, sir. Now, may I request Dr. Arun to please come onto the stage to felicitate Dr. Saneesh.
Thank you.
Now, may I request Dr. Sudesh K to please come onto the stage to felicitate Dr. Arun and Dr. Ruby. Thank you, sir.